It's now my great pleasure to introduce Clinical Professor David Smith. I've known David for a long time, so I can speak with some authority on his credentials. David is a director of APACI and has been for many years, in fact, one of the founding directors. He is the clinical professor in the School of Medicine at the University of Western Australia. He's also the clinical virologist and director of the National Influenza Centre at Pathwest Laboratory Medicine in Western Australia at the Queen Elizabeth II Medical Centre. He's also the chair of the National Arbovirus and Malaria Advisory Committee. His interests are largely in public health issues, including mosquito-borne viruses, influenza, and other respiratory viruses, emerging infections, new diagnostic technologies, and laboratory-based surveillance. He has authored and co-authored more than 220 book chapters and medical journal articles, and of course he has been in many conferences, as he is about to hear, and he is chairing session 4. Over to you, David.
Thank you very much. Hope you can hear me okay. I have to apologise for the picture in that presenting slide. That was a while ago. As you can see, I've got less hair and the one that remains is grey now. But this is the real me. So look, it is a great pleasure and thank you for asking me to do this. And we have a very august group of speakers coming up in this session. And you're not here to hear me, so I'll get on with introducing those speakers now. So, excuse me if I have to read some of the details. The first speaker is Dr. Parvez Kaul. He's a professor of pulmonary and internal medicine, and he has a number of associations with the Sherry Kashmir Institute of Medical Sciences in Srinagar in Kashmir. He has a number of international links and with both professional associations and of course with advisory bodies, and he is a member of the National Advisory Group on immunisation for the Ministry of Health in India. So I'm going to ask him, he's going to talk to us about a very important vaccine preventable disease, which is pneumococcal infection. So we will let you take over now, Professor Kaul. Do you need to share your screen, or is the...
I think the recording is going to play.
Okay. Good. Thank you.
Thank you for that introduction, and thank you, APACI, for having me as a part of this respiratory disease workshop for India. And I have been tasked to talk on the newer developments in pneumococcal vaccination, where to now with pneumococcal vaccines. I must extend thanks to MENA-ISAN, the IAP, ICS, and the API for having organized this workshop. Pneumococcal disease is caused by Streptococcus pneumoniae, which is a gram-positive diplococcus having a polysaccharide capsule, which functions as an important virulence factor and defines the serotype, and is a major determinant of virulence because it overweights the various body's defenses for killing the Streptococcus pneumoniae once it infects the body. There are more than 90 known serotypes based on various serotypes obtained globally, and they vary according to age and distribution across various geographic regions in the world, and are not equally pathogenic. Nearly 27 of the serotypes accounting for about 90% of the most frequent isolates. estimating the morbidity, mortality, and etiologies of lower respiratory tract infections in 195 countries from 1990 to 2016. And under the aegis of the global burden of disease studies. In 2016, we estimated that lower respiratory tract infections caused around 2.4 million deaths, and Streptococcus pneumoniae was the leading cause of LR infections, morbidity, and mortality globally, contributing to more deaths than all other etiologies combined. That was nearly 1.2 million deaths. Back home, we looked at the epidemiological transitions of disease, and we found that of the important 5 causes that cause premature deaths in 2016, the 2 slots are occupied by lower respiratory tract infection and COPD, which are 2 diseases that are important in the context of today's talk. Does Streptococcus pneumoniae figure out as an important pathogen in causation of community acquired pneumonia? We looked at 225 patients from 2012 to 2014 who were admitted with a community acquired pneumonia. And apart from routine microbiological studies, we did the molecular studies to look for other pathogens, and we were actually started to know that to find that Streptococcus pneumoniae indeed was the commonest pathogen retrieved from these patients, leading to nearly 1/3 of the total of the community acquired pneumonias. Subsequently, we did a meta-analysis and a systematic review of all the studies that had been performed in India in adolescents and adults, and we found that there were 1,435 patients were totally involved in these studies, and a ballpark figure of around 20% of the times the etiology could be attributed to Streptococcus pneumoniae. Shifting gears a bit, another malady that actually confronts the pulmonologists all across the world is chronic respiratory disease, and of those, asthma and COPD occupy the top slots. And COPD in India has increased from 28 million to about 55 million in 2016, and this we demonstrated on the basis of a GBD study again. And we know that the life course of a patient with chronic obstructive lung disease is punctuated by various exacerbations that not only lead to acute reduction in the lung function, which normally happens in these patients, but also contributes significantly to morbidity and mortality in these patients. And we looked at the mortality in around 150 plus patients with chronic obstructive lung disease who had survived an acute exacerbation. And we were horrified to note that around 40% of them are dead at 2 years of age, and rate of mortality which is much higher than the famed acute myocardial infarctions that have actually been in the limelight. And for prevention of chronic obstructive lung disease, COPD, Streptococcus pneumoniae does figure out to be an important pathogen, and we need to note that around 10 to 15% of the exacerbations are caused by Streptococcus pneumoniae. So we need to have a strategy for preventing these exacerbations. So looking at this disease burden from the perspective of causing pneumonias as well as exacerbations of chronic obstructive lung disease, we noted that we need to have strategies for prevention of pneumococcal disease in our pulmonary practices in India. And vaccinations have been one of the important most successful public health interventions that has caused a reduction in the morbidity and mortality of disease, nearly wiping out certain diseases from the face of the earth, like smallpox. And given the backdrop of the pneumococcal disease, WHO considers it to be a high priority area for both industrialized and developing countries. And the pneumococcal vaccines that are available with us are directed against the capsule polysaccharide. We have the polysaccharide vaccine and the conjugate vaccine. The polysaccharide vaccine, once it is administered, causes B cell differentiation into plasma cells. However, it is without affinity maturation, and there is a predominant elaboration of IgM and IgG2 class of antibodies, which are not high affinity antibodies. And there is a depletion of the existing memory B cell pool. However, once this polysaccharide capsule is conjugated to a protein carrier, like we have in Corynebacterium diphtheria, what happens is that there is an additional recruitment of T cells, which leads to development of higher affinity antibodies, that is IgG1 and IgG3 class. There's an affinity maturation, and also there is formation of memory B cells, which help in anamnestic response once a subsequent booster dose of pneumococcal vaccination is administered. These are the serotypes containing 2 vaccines. We have 6A as unique to PCV13, and there are 11 serotypes that are unique to the PPSV23. This is the current ACIP guidelines for pneumococcal vaccinations amongst adults. Adults from 19 to 64 years having no underlying condition, no vaccination is recommended. However, if a person is beyond 65 years of age, then we recommend PPSV23 to all. And if there is a decision to be taken about the administration of PCV also, it has to be based on the shared clinical decision between the physician and the patient. If there is a patient who has an underlying chronic medical condition like chronic heart, lung, liver disease, or alcoholism, diabetes, or is a chronic smoker, then PPSV23 is recommended. And again, if you decide to give PCV13, it has to be based on a shared clinical decision. However, once you have an immunocompromising condition or you have a cochlear implant or a CSF, it is recommended that both PCV and PPSV23 be administered with a preferable gap of around 1 year. However, if you desire to administer them quickly, then there should be a gap of around 8 weeks between the 2 vaccines. Are they effective against the clinical outcomes? And these are the data for the invasive pneumococcal disease. The CAPITA trial demonstrated that there was a vaccine effectiveness of around 75 to 76%. And these are certain active bacterial core surveillance studies from the US, where the vaccine effectiveness ranged from 47 to around 68%. Against vaccine type pneumonia, the vaccine effectiveness ranges from 38 to 45%, depending on various studies. And against mortality, there's no response for the Dutch study, whereas the hazard ratio was around 1.67 for the study. What about PPSV against vaccine type invasive pneumococcal disease? These were pooled vaccine effectiveness estimates or observational data that were actually reviewed by the ACIP committee for which was convened in June of this year for recommendations for PCV20 and PCV15. And the pooled vaccine effectiveness of these observational studies against invasive pneumococcal disease by PPSV23 was 38%. And against vaccine type pneumococcal pneumonia, it ranged from -2 to around 34%. And for mortality, the vaccine effectiveness ranged from around 7 to 35%. Against this backdrop, the various physician societies recommend pneumococcal vaccination in patients that they cater to, be it the Association of Physicians of India, the Indian Society of Nephrology, Allergy, Mass Gathering Society, or the Geriatric Society of India. They have recommended pneumococcal vaccination in their patients, in adult patients, because it is not contained in the universal immunization program for adults by the Ministry of Health. And they have actually recommended that the age at which pneumococcal vaccination should be offered should be around 50 years, except for the Indian Society of Nephrology. Last year, the Indian Chest Society and the National College of Chest Physicians came up with consensus recommendations for pneumococcal vaccination, and Dr. Raja is always talking about it in greater detail. And these guidelines are largely aligned to the ACIP, and except that they have again recommended 50 years to be the age to obviate the immunosenescence playing a part, and then a shared clinical decision on conjugate vaccine if and when the physician decides to give it in conjunction with the PPSV23. So what are the current challenges to the current vaccination strategies? And the challenges obviously are that we cover only a small subset of around 23 serotypes of the around 100 serotypes that are there. And as a result, there is an emergence of non-vaccine serotypes, and there is an inadequate protection against these non-vaccine serotypes, as also against unencapsulated Streptococcus pneumoniae, which are not included, obviously, in the vaccines. And there has been an antibiotic resistance that has been creeping up as not only of the vaccine types, but also in the non-vaccine serotypes. We do not have a great data from developing countries about the seroepidemiology of various serotypes, and as such, we don't know what it would be the efficacy. There's a low immunogenicity of the polysaccharide vaccine in the very young, and then cost is an issue. This is what happened to the incidence rates of invasive pneumococcal disease in children under 5 years of age once PCV was introduced in 2010. And as you can see, there has been nearly a 67% reduction in the incidence of all invasive pneumococcal disease, as is depicted by the blue line in this graph. And it was more so for the vaccine serotypes contained in the PCV13, and to the tune of around 90%. The non-vaccine PCV remained largely unaffected. And similar trends were observed in the age groups of 19 to 49 and 50 to 64 years, with a reduction of around 46 and 24%. However, the reduction of incidence was seen in vaccine serotypes contained in the PCV13 and not in other serotypes. And in patients, in people who are aged more than 65 years of age, after the introduction of PCV in children, there was a reduction of the serotypes contained in the PCV13 in adults, even when it was not introduced. But subsequent to the introduction of PCV13 in adults more than 65 years of age, there was not a marked change in the incidence rates of invasive pneumococcal disease. So the impact of pneumococcal conjugate vaccine in the United States is that once it was introduced in the PCV, it was introduced in the children, it resulted in a reduction of vaccine-preventable pneumococcal disease burden in adults. But once it was recommended for, and introduced in adults aged 65 years or more, we documented a reduction in pneumococcal conjugate vaccine 13 type pneumococcal pneumonia, but there was no impact on PCV type invasive pneumococcal disease. And the serotype that was actually coming up was serotype 3. This is the serotype replacement trends that have been witnessed in various countries like Australia, Finland, France, Norway, and USA. As you can see, that there has been a replacement of the serotypes from the pre-PCV to the post-PCV times. And we have these color-coded, we have a replacement of the serotypes by sometimes by vaccine non-vaccine type serotypes or other serotypes that were not contained in the conjugate vaccine that was introduced. As a result, the vaccine manufacturers are constrained to increase the valency of the conjugate vaccines that are available for administration. And in this connection, in June 2021, Pfizer announced the US FDA approval for its 20-valent conjugate vaccine, which contains additional 7 serotypes, as can be seen in this figure here. So it's in addition to the PCV13. And then it was this approval came on the basis of its non-inferiority against PCV13 and PPSV23 against the serotypes which are shared, and it was similarly effective in ages of 50 to 59 as well as 60 to 64 years, and was at the same time found to be safe. About a month later, Merck, the manufacturer of PCV15, announced its US FDA approval of its PCV15 vaccine. And it was again based on a non-inferior immune response generated by its PCV15 against the serotypes contained in the PCV13, and a superior response against the serotypes 3, 20F, 2F, and 33F. And again, this was based on its non-inferiority against PCV13 PPSV23, and a superior immunogenic response in terms of seroresponse and attainment of geometric mean titers of IgG when compared to a PCV13 PPSV23 immunogenicity. And again, it was found to be safe. The next steps would be the refining of the policy by the ACIP on PCV 15 and 20, which is expected to be somewhere in October of this year. However, despite PCV 15 additionally covering 15% more serotypes, and PCV 20 covering nearly 30% more serotypes that are not contained in the PCV 13, there's a significant burden of non-vaccine serotypes as shown by the green part of these columns. So we need to have other vaccine targets. We need to have conserved bacterial proteins which are conserved across the various serotypes. And in this context, it's important to note that there are certain vaccine targets, like we have pneumolysins, which is a pore forming toxin contained within the cell. And then there are cell surface antigens like the pneumococcal surface protein A or the choline surface binding protein, then choline, pneumococcal choline binding protein, and the histidine triad protein. They're all available for being targeted for development of vaccines, and antibodies targeting each of these proteins have been shown in experimental studies to convey protection to animals against pneumococcal disease. And not only that, it is proposed that we could develop vaccines against more than one target, so making multivalent protein or hybrid pneumococcal vaccines, which would be the recipe for next generation vaccines. And in this context, live and whole cell vaccines and combine of the capsule and protein combine is also being investigated. The Serum Institute of India indigenously developed a vaccine called Pneumosil, which is not only competitively priced, affordable, but also has the advantage of serotype 6A and 19A, which cause a lot of disease in India. And this was based on its immunogenicity and safety profile, on the which was demonstrated in a phase 3 randomized double-blind non-inferiority trial in Gambia, wherein it was demonstrated to be non-inferior to Synflorix, which is another 10-valent vaccine available in the world, and it was superior in its immune response to the serotypes which were not contained in Synflorix. A word about coverage. We don't have much data from India, and pneumococcal vaccination, even though it is recommended in various disease states, the vaccination coverage in this study in 2014 was found to be just 9% in all diabetics, and of the 1,100 diabetics that were actually surveyed, and all of them had actually been recommended to get vaccination by their physicians. So it is important that vaccines are taken by the patients only once prescribed by the physicians. So it's important that we have an augmented sensitization of the physician providers for vaccination. So coming to my last slide, ladies and gentlemen, where to for pneumococcal vaccinations in India? We need to consolidate the pneumococcal vaccine rollout that has been rolled out just this year, the PCV 13 and 10, and we must improve the uptake. We must await the efficacy and effectiveness data for PCV 15 and PCV 20 on the global level, and await the recommendations, the final recommendations of the ACIP. We must have a routine seroepidemiology of pneumococci in order to tweak the vaccines to our own geographies. We also should enhance indigenous manufacture of affordable vaccines. And then there is a possibility that multivalent protein vaccines, hybrid vaccines, may be the future of pneumococcal vaccines, and never vaccines need to be developed based on conserved targets across various serotypes. Thank you for your kind attention.
Thank you very much, Professor Kaul. That was excellent. We will have the panel discussion or group discussion at the end of the session. So I think we'll move on to the presentation, the next presentation. And it's my pleasure to introduce somebody who many of you will already know, of course, Kenta Sibarao. Kanta is the director of the WHO Collaborating Centre for Reference and Research on Influenza in Melbourne, and also professor in Department of Microbiology and Immunology at Melbourne University and at the Doherty Institute. She has had a very high international profile in the area of respiratory viruses, with a number of appointments, of course, there in associations within the US that is ongoing, and an impressive publication record. And we were very fortunate to be able to have her come and join us in Australia. So Kanta is going to talk to us today about the holy grail of universal influenza vaccinations. So I'll hand over to that. Thank you very much.
Thank you, David. And I'd like to thank the organizers for this opportunity to speak to you. And let me try to get to my slides here. There we go. So it's my pleasure to speak to you at this 2021 APACI Respiratory Disease Workshop. And the topic I was asked to talk about was universal influenza vaccines. So we've been hearing about bacteria most recently and COVID before that. So just to set the stage and remind people that there are 4 types of influenza viruses, A, B, C, and D. Influenza A and B viruses cause seasonal influenza epidemics. And there are 2 influenza A subtypes that are co-circulating, AH1N1 and AH3N2. And the influenza B viruses now are co-circulating in 2 lineages, the B Yamagata lineage and B Victoria lineage. Now, all 4 of these viruses cause an clinically indistinguishable illness that is referred to as influenza. But the other thing to note when we talk about different influenza types is that only influenza A viruses cause pandemics. So here's a schematic of an influenza A virus, and the genome is comprised of 8 different gene segments in the case of influenza A and B. And the 2 surface proteins, the hemagglutinin and neuraminidase that I'll talk about again, are the focus of the vaccine response. So why do we worry so much about influenza, and what is the burden of disease? So for years, we used to say that the estimates were between 250 to 500,000 deaths globally per year. But the CDC actually led a very large multi-country study, and they got an estimate from 47 countries over a 20-year period. And the numbers came out strikingly similar to what we used to say, which is that there are 291,000 to 645,000 deaths annually attributable to influenza. And this works out to 4 to 8.8 per 100,000 persons. The mortality from influenza is highest in sub-Saharan Africa, Southeast Asia, and by age group in people older than 75 years of age. In children under 5 years of age, there is significant morbidity and some mortality. And there's an ever-present threat of pandemic influenza. So influenza viruses use 2 different distinct mechanisms to cause antigenic change. The one we live with continuously with seasonal influenza is referred to as antigenic drift. And here there's a gradual alteration of the influenza surface proteins, mainly the hemagglutinin, within a subtype, resulting in the inability of antibody to previously circulating strains to neutralize the new virus. And this can result from point mutations in the hemagglutinin and in the neuraminidase. So genetic drift can be monitored by sequencing the hemagglutinin, but genetic drift doesn't always lead to antigenic change. So we really need both. And the composition of the influenza vaccine has to be updated annually to keep up with antigenic drift. Antigenic shift is the other major mechanism by which influenza viruses change. And on this schematic, as I pointed out earlier, only influenza A viruses undergo antigenic shift. And it's because there are a number of different hemagglutinin and neuraminidase subtypes that are present in nature. And if you look at this schematic, you could see that all of the subtypes have been isolated from waterfowl and shorebirds, all the first 16 HA subtypes. The 2 most recent ones, H17 and H18, have been isolated or identified in bats. And so their role in causing a pandemic of influenza is not yet clear. But what is notable is that we really only have 3 hemagglutinin subtypes that have caused sustained outbreaks of illness in humans, H1, H2, and H3. And you can see that there are a smattering of different subtypes that have been identified in pigs, horses, seals, dogs, and aquatic mammals. Now, the neuraminases come in different subtypes as well. We used to talk about 9 different neuraminidase subtypes, and all of them have been identified in waterfowl and shorebirds, and only 2 neuraminidase subtypes, N1 and N2, had been identified in humans. Again, you see a smattering in different species, and the most recent 2, N10 and N11, were identified in bats. So the natural cycle of influenza viruses are in waterfowl and shorebirds. And what is amazing is, of course, that these viruses have reached ecological stasis in their natural hosts. So these viruses replicate to very high titer in the GI tract of birds and don't cause disease. But when they spill over into a non-natural host, which would be domestic birds, it would be poultry, it would be chickens and turkeys, or occasionally in mammals, and primarily in pigs and in humans, they can result in disease and the potential to cause a pandemic. So when we look back at all over the last many years, 60 years, we can see that there are a number of different hemagglutinin subtypes, a different number of different avian influenza viruses that have actually caused infections in humans. We used to think that avian viruses could only infect humans after they reassorted. But you can see here that we've got a number of different viruses that have caused documented infections in humans. And what I've circled are the ones that we pay a lot of attention to, which are the H5N1 and H7N9, and H5N6 and N8, and now H9N2 infections. And 2 of these, the ones boxed in red, are the avian influenza or bird flu viruses that have caused significant disease in humans, including, of course, in India, there's been a recent H5N1 case as well. So as I said, the natural reservoir are in waterfowl and shorebirds, and there were the 16 HA subtypes and 9 neuraminidase subtypes that occur in waterfowl and shorebirds. And they spill over into humans sporadically. And when they are able to cross the species barrier and spread efficiently from person to person, they can cause a pandemic. So we've had 4 pandemics in the last 102 years. The 1918 Spanish flu pandemic, the 1957 H2N2, which was the Asian flu pandemic. 1968 was the introduction of H3N2. And then in 2009, the introduction of the H1N1 2009 virus, actually that one came directly from pigs. And what you can see is that once a virus is introduced into humans, what this shading represents in the yellow is that there's gradual antigenic drift. So at this point, we have 2 viruses co-circulating. I'm sorry, this arrow should have ended there. We have 2 viruses co-circulating, H1N1 PDM09 and H3N2, in addition to influenza B viruses. So what are the consequences of these pandemics and what is the economic impact? Of course, the world is still in the midst of a COVID-19 pandemic, so it's much more present, all of our information about the economic consequences of a pandemic. But these are some data that were put together by the World Bank and other agencies to look back at the pandemics of the last century, the Spanish flu, the Asian flu, the Hong Kong flu, and the 2009 pandemic, and look to see what sort of estimated case fatality rates there were and how much estimated excess mortality occurred worldwide. And it ranged from 20 to 50 million excess deaths worldwide with the H1N1 pandemic of 1918 to the more modest 100,000 to 400,000 deaths attributed to the 2009 pandemic. But what is really remarkable is that the annual global cost of moderately severe or severe pandemics would be $570 billion US, or 0.7% of the global income. But in contrast, pandemic preparedness has been estimated to cost less than $1 per person. So vaccines are definitely a worthwhile investment. So how do we go about these? So as I told you before, the influenza virus has a segmented genome, and there are two major surface glycoproteins that I've identified on this slide with the red arrows, the hemagglutinin and the neuraminidase. They are the targets of the protective antibody response. So this is a cartoon in which we put together what happens during an influenza infection. And there you can see that on the y-axis, which is the titer or the magnitude of the response, there's no scale because we put together data from so many different areas. But what happens in a primary infection, and on the x-axis, you're looking at time in terms of days, that with a primary infection, you get a very rapid replication of the virus. And it peaks at about 2 to 4 days post-infection. And when the virus replication peaks, it's associated with upper and lower respiratory tract symptoms and fever. There's an innate immune response. It's not on the slide. And you could see that the T cell response comes up. It starting at about 5 days post-infection. And gradually that is associated with clearance of the virus. The antibody response in the serum and at the mucosa comes up a bit slower, and that persists for much longer. So at some point in the future, if you're re-exposed to an influenza virus, in the presence of serum and mucosal antibody, the consequence of that infection is that the peak of viral replication, this purple line, is reduced. And that reduction is associated with protection from fever and lower respiratory tract infection. So the illness is limited to an upper respiratory illness. The CD8 T cell response comes up a bit sooner, but if it is, it needs to be recalled from memory. So T cell vaccines alone don't work as well as antibody-mediated vaccines. So the principle of our currently licensed vaccines is on this cartoon, and that is that if you could generate a serum antibody response that would protect you from developing severe illness following infection, that is desirable, and that is the principle of our currently licensed vaccines. Now, there are, however, significant limitations to our current vaccines. Vaccines take months to manufacture. There's reduced effectiveness when the vaccine and epidemic strains are antigenically mismatched. So we update our vaccines each year based on what we think will happen, what we predict will happen with the virus evolving in nature. But yet, since it's taking months to make the vaccine and the virus is continuing to evolve in nature, there can be a mismatch. The other thing we know is that there's been suboptimal efficacy of the vaccine in the elderly. There's a short duration of protection, in part because antigenic drift results in the need for annual vaccine reformulation. And of course, as I said, antigenic shift is the introduction of a completely new hemagglutinin and or neuraminidase, and that would require a completely new vaccine. Now, most of our currently licensed influenza vaccines are made in embryonated hen's eggs. So you might wonder why it takes so long from the time we select what goes into the vaccine to actually distribute and administer it. And it's because there are many, many steps in the process, and that's what takes so long. So the goal of a pandemic influenza vaccine is to prevent severe illness and death from pandemic influenza and its complications. Ideally, we would want a vaccine that would induce a systemic and mucosal immune response directed at the hemagglutinin, the neuraminidase, and conserved internal proteins of the virus. And we would want something that would protect against a broad range of influenza viruses within a subtype and across all subtypes. So this is taking us to where we're going with universal influenza vaccines. Now, for years, the influenza field said, you know, we know how to make vaccines. There's a universe of viruses out there. We don't know which one is going to cause a pandemic. So we should wait until a virus emerges, and then we hurry up and make vaccines, which sounds good in principle. But what we learned in 2009 was that the pandemic H1N1 vaccine, the decision to make a vaccine was made very early, and we knew how to make vaccines. We had experience with H1 vaccines. And yet, with all of that, we only administered vaccines to the first group really at the peak of the H1N1 cases. And most people, the H1N1 pandemic vaccine became available to everybody well after the peak of infection. So that really took us back to the drawing board to say, well, we cannot just wait and hurry up and make a vaccine. We should probably have some vaccines made ahead of time. So how do you do this? So this is a gradient of universality of the vaccine and the nature of protection. And so what we have here is that if you have our current vaccines for seasonal influenza are very strain specific. They will cover currently circulating strains. Now, what if we wanted to broaden it so that we didn't have to keep up with antigenic drift, so that we covered all strains within a single HA subtype? That would be a subtype specific vaccine. We could have a multi-subtype vaccine where maybe we could combine and protect against several subtypes. Or we could cover a large group. And then the holy grail, the ultimate goal is to have a universal influenza vaccine where we cover all influenza A viruses, possibly all influenza viruses A and B. So we have a couple of options when we think about doing this. We could use the conventional approach, which is to make strain-specific vaccines. We could try to enhance the breadth of cross-reactivity and make subtype-specific vaccines. And then what's referred to as the game changer approach is something completely novel, and that is a universal influenza vaccine. So the strain-specific vaccines are to use the principles that we use now and the technology that we use now. And this would mean that we monitor antigenic drift and genetic drift through surveillance. We identify when an antibody elicited against the previous vaccine fails to cross-react, and then make a new vaccine. We could improve the breadth of immunity by using adjuvants, by changing the platform to use whole virion vaccines. We could combine platforms. We could make a number of different, we could change the way we select strains that go into the vaccine viruses. We could select antigenically advanced variants, or we could make an ancestral or computationally optimized broadly reactive HA. Or you could do a multivalent vaccine with many different HAs in it. Or you could combine some of the internal protein genes that are very highly conserved, like the NPNM1. So the NIH actually held a meeting to talk about what a universal influenza vaccine should look like. And so this is actually the report of that meeting. It was in the Journal of Infectious Diseases in 2018. And the criteria that the NIH proposed were that a universal influenza vaccine would have to be at least 75% effective against symptomatic influenza virus infection. It should protect against all influenza A viruses. Influenza B viruses would be a secondary target. We would need durable protection that would last at least 1 year and preferably through multiple seasons. And it should be suitable for all age groups. So what are the targets of universal influenza vaccines? So I'll talk to you a little bit more about the hemagglutinin in a minute. The neuraminidase is largely ignored, but it changes much less frequently than HA. So the neuraminidase is getting a lot of attention. The M2, NP, and M1 or T-cell-based protection are under consideration. And of course, with all that we've learned with the COVID-19 vaccines, we could try new platforms like mRNA. So when we think about the hemagglutinin, the vaccines that we make now direct all the immunity to the head of the hemagglutinin. And this is a schematic of the influenza hemagglutinin. There's a very large globular head and a stalk. So what is in red here on this head are all the residues that have changed. So almost all the surface accessible residues change because of antigenic drift. But in the stem of the HA, there's a highly conserved epitope. And so the idea is that maybe instead of focusing on the head, we should focus on the stem. And so when you take all the different 18 hemagglutinin subtypes and you make a phylogenetic tree and look at relatedness, they fall into two major groups, group 1 and group 2. So H1 that we live with as a seasonal virus, and H3 are in two different groups. Now H5 sits in group 1, H7 sits in group 2. So and all of this phylogenetic tree is largely based on differences in the HA stem. So the HA stem has been a major focus of universal influenza vaccines. And some of the strategies that show promise now are to actually make a stabilized HA stem and put it on a nanoparticle. So the immune system really likes to see particulate antigen. And so you can make a ferritin nanoparticle with multiple molecules attached to it. And now they're making mosaic nanoparticles where you could have different HAs on the same nanoparticle. And on this schematic here, I've tried to summarize, if we go from our current strain-specific vaccines all the way out to a universal vaccine, we gain breadth of the vaccine as we add adjuvant or focus on the HA stem or make something that's a live attenuated vaccine. But the longevity of the immune response is disproportionate. So we have much more long-lasting immunity when we work with the strain-specific vaccines rather than the universal. And of course, then there's the time for vaccine development. So in summary, a universal influenza vaccine would provide protection against antigenically drifted strains, as well as pandemic strains arising from antigenic shift. There are scientific and technological advances that are very exciting and very promising, but there are some challenges that I'll talk about in the next slide. The lessons from COVID-19 vaccine efforts, including new platforms and vaccine access, will all be very relevant to influenza vaccines. So while there's been this enormous excitement about the science underlying the concept of universal influenza vaccines, we are left with some technical challenges. We need to identify targets that are conserved across a wide range of influenza viruses. We need a vaccine strategy that will induce an immune response that is sufficiently robust to confer protection, that's elicited at the appropriate site, that is in the lungs or at the mucosal surface, without causing adverse events like immunopathology. From the regulatory standpoint, we'll need immune correlates of protection, and we'll need assays to measure them. And in terms of implementation, that'll be a whole new question: who should be vaccinated, when, and how often? Now, some of these challenges are things exactly what we've been talking about with COVID-19. And so there are a lot there. It's quite, some of the discussion will be very reminiscent of the panel discussion you just heard. So I will say, though, that everything that we do in preparing for a pandemic gives us better tools for seasonal influenza vaccines, and everything we do for seasonal influenza vaccines prepares us better for the eventuality of an influenza pandemic. And with that, I will stop and thank you very much for your attention. And over back to you, David.
Thank you very much for that excellent and very understandable presentation. So thank you for that. We'll move on to the next presentation now. We have Dr. Prashant and Cheded, who is going to talk to us now about COVID, as if we couldn't get back to that, and treatments. He is a director and of the Lung Care and Sleep Center in Mumbai. He's a pulmonologist with a couple of hospital appointments there, chairman of the Intervention Pulmonology Group at the European Respiratory Society and secretary of the Indian Association of Bronchology, and also has an attachment with the University of Basel in Switzerland. He has, of course, extensive professional experience and an academic record. And he is, as I said, going to talk to us today about therapeutic interventions for COVID-19. So thank you very much, Dr. Chedid.
Yeah, thank you very much for this introduction. And what I'm going to do in the next 20 minutes is talk to you about monoclonal antibodies. And I've been asked to speak about other COVID therapies, but in interest of time, I'll just stick to budesonide. So the reduced risk of COVID-19 hospitalization, asthmatic and COPD patients was observed in this particular review, in Expert Review of Respiratory Medicine, which was already published here. And there seemed to be a reduced risk of hospitalization in patients with asthma and COPD. And it was hypothesized whether it was because of the use of inhaled corticosteroids. So taking in this observation into account earlier on, there was the question asked, can inhaled corticosteroids reduce the morbidity due to COVID if initiated early in the course of disease? And therefore, this gave birth to the STOIC study, the steroids in COVID study, inhaled budesonide in the treatment of early COVID-19. And this was published earlier this year in the Lancet Respiratory Medicine. So the aim of the study was to look at the effect of intervention with inhaled corticosteroids in SARS-CoV-2 and COVID-19 infections. And the primary objective was to demonstrate a reduction in severe illness from COVID-19 using inhaled corticosteroids at the onset of COVID-19 symptoms. So if you look at the methodology, it was a community setting in Oxford in the UK. Inclusion age was more than 18 years. And within 7 days of the onset of cough, fever, loss of smell and taste. And the important factor here was, yes, everybody needed to have a swab done, but it was not necessary to have a COVID test result at the time of randomization. And budesonide was continued till symptom recovery or till the primary endpoint was concerned. So there were two groups. One, the usual care plus budesonide given 800 micrograms twice a day versus usual care. And the usual care consisted of antipyretics and NSAIDs such as aspirin, ibuprofen, and honey for symptom relief. The primary endpoint was COVID-19 related urgent care visit, emergency department assessment, or hospitalization. And the secondary endpoints were clinical recovery, symptoms, temperature, oxygen saturation, and viral load. When you look at the baseline demography, both the groups were very well matched in age, gender, race, BMI, more comorbidities, etc. And also as far as the presence of symptoms in both groups, the symptoms were equally matched. And budesonide was taken for a median of 7 days, and there were 94% patients who were RT-PCR at the time of randomization. The endpoint was very striking. The COVID-related urgent care visit, emergency department assessment, or hospitalization was seen in only one individual in the budesonide group compared to 10 individuals in the usual care group, and there was a relative risk reduction of 91%. Looking at the days to clinical recovery, the median days was 7 days for the budesonide group versus 8 days for the usual care group, mean days of 8 days for budesonide versus 11 days for usual care group, and therefore this data showed that the recovery was quicker symptomatically in budesonide group compared to the usual care group. Looking at the Flu-Pro questionnaire, the symptom burden was again in favor of budesonide. That means there were less symptoms associated with budesonide compared to usual care. As far as the common cold questionnaire is concerned, the symptom burden score in the common cold questionnaire also was in favor of budesonide. That means the symptoms were lesser as far as the inhaled budesonide group was concerned. Now, the body temperature, very interesting. For the first 14 days, the trend in daily recorded temperature for the two arms indicate that the daily highest temperature fell more rapidly in the budesonide group compared to the usual care group, and the amount of antipyretics used in the budesonide group were lower than in the usual care group. So the summary was that there's a relative risk reduction of 91% on COVID-19 related urgent care visit, emergency department assessment, or hospitalization with budesonide compared to usual care. The clinical recovery was earlier. The mean proportion of days with the fever was less severe and lower in the budesonide group, and the number of individuals needing as required medications, antipyretics, was less in the budesonide group, and there was a reduction in the symptom burden in the budesonide group compared to usual care. The principal study also looked at a slightly different population, and the utility of budesonide was evaluated in individuals more than 65 years of age or more than 50 years of age with comorbidities, and the inclusion criteria included symptoms or being unwell for less than equal to 14 days with suspected or confirmed COVID-19 symptoms. And the treatments patients were randomized to usual care and usual care plus similar dose of inhaled budesonide at 800 micrograms twice a day. And the primary endpoints were time to first reported recovery, defined as the first instance that a participant felt recovered, and hospitalization or death associated with COVID-19. And in this study also, inhaled budesonide reduced the time to recovery by a median of 3 days in people with COVID-19 with risk factors for adverse outcomes. So if we look at this, I mean, clearly we had a fantastic the data from the STOIC and the principal study talking about a very simple therapy, with asthma therapy, which is available across the world and showing such effectiveness. Now I move to the next topic or the next point of discussion, that is the antibody cocktail, that is casirivimab and imdevimab, two distinct antibodies which bind non-competitively to the COVID-19 virus cell surface. It prevents the virus from infecting healthy cells, and using two antibodies protect against the emergence of resistance. So this CAS-IMD cocktail has been authorized for use in mild to moderate individuals with COVID-19 who are at a risk of getting severe disease. And a very important clinical question, what is high risk? High risk are those individuals more than 60 years, obesity, having morbidities such as cardiovascular, lung morbidity, diabetes, chronic kidney disease, liver disease, immunosuppressed or transplant or have received organ transplantation or are on medication which can cause immune weakening such as corticosteroid or mycophenolate, etc. So this is the group that was defined as a high risk individual. And what has been the indication for which has been approved, and what is the dose? Of course, I will come to the clinical study subsequently. For the treatment of mild to moderate COVID-19 in adults and pediatrics 12 years of age and older with laboratory confirmed SARS-CoV-19 infection who are at a high risk of severe COVID-19 and do not require oxygen. So this was the EUA emergency authorization for this particular indication. I will also discuss with you about the hospitalized patients subsequently, and it has been approved at a combined dose of 1200 milligram, that is 600 milligram of each drug administered by intravenous infusion or subcutaneous route. In Mumbai, we typically are using the intravenous infusion, and the casirivimab and the imdevimab should be given together as soon as possible after the SARS-CoV-2 results are available and within 10 days of symptom onset. Of course, there are some guidelines talking about less than 7 days, some guidelines talking about less than 10 days within the symptom onset. Now, where do you place COVID in the COVID-19 therapy by illness phase? And if you see budesonide as well as monoclonal antibodies are placed here in the chart at early symptomatic disease, not hospitalized with limitations. So that's where inhaled budesonide is recommended. And then we have monoclonal antibodies. We have bamlanivimab and itesivimab, but that's not available with us. What is available with us is casirivimab and imdevimab, and that's what I'm going to discuss with you. So this is the early placement or the placement of these monoclonal antibodies and budesonide. So what is this trial? This was a phase 3 trial which looked at giving the casirivimab plus imdevimab versus placebo in outpatients with COVID-19. The key inclusion criteria were onset of symptoms less than equal to 7 days before randomization, positive COVID RT-PCR, patients had to be more than age 18 and had to need a more than equal to 1 risk factor, which would define them as at a high risk factor for COVID-19, and the high risk factors I already discussed earlier. The endpoint was proportion of participants with COVID-19 related hospitalization or all-cause death through day 29. And here, if you look at the right side of the slide, the results, there was a 70 and 71% relative risk reduction in COVID-19 related hospitalizations or all-cause deaths in participants who received the monoclonal antibody cocktail. Symptom resolution was better, and in hospitalized patients, it reduced the proportion of those needing ICU care and were discharged earlier. So it's a generally well tolerated. There were no safety signals here. And this slide shows the various doses that have been checked or that have been used or trialed in COVID-19, and shows that the side effect profile is quite good and not very severe side effects. I will discuss about the side effects subsequently again. So in ambulatory, so the summary is in ambulatory patients, the investigational antibody cocktail casirivimab and imdevimab reduced hospitalization or death by 70% in non-hospitalized patients with COVID-19. Casirivimab and imdevimab also significantly shortened the duration of symptoms by 4 days. And the most important thing is the 2,400 milligram and 1,200 milligram doses tested in the phase 3 study had similar efficacy across all endpoints, and it was well tolerated. And because the 1,200 and 2,400 has been tolerated, has a similar efficacy across all endpoints, the dose that is recommended is 1,200 milligram. The vial is available, both the vials are 1,200 milligram each, and therefore what is done in practice is that one set of vials is used to treat 2 patients. So how's it administered? It can, we typically use intravenous administration, can be given in 50 ml, 100 ml, 150 ml, or 250 ml of normal saline, and given over 20 to 30 minutes. And both 600 milligram of casirivimab and 600 milligram of imdevimab are added to the same infusion bag and administered together as a single intravenous injection. And of course, if you're going to give it as subcutaneous, there is a protocol given. Syringe 1 has 300 milligram. And you've got 2 syringes with 300 milligram each of casirivimab and 2 syringes of 300 milligram of imdevimab, and they are given concurrently either in the abdomen or on the thigh. Now, again, another important thing, because these medications these vials can be used in 2 patients. The unopened vial need to be refrigerated at 2 to 8 degrees. If the vial is punctured to withdraw the first dose, and if the second dose withdrawal is not required immediately, it can be stored at for 16 hours at room temperature, or 48 hours refrigerated between 2 to 8 degrees. And I think this is the most important thing, that once you open the vial, it has to be utilized within 48 hours when it is needs to be refrigerated. Now, this is another important data, the recovery study, which looked at casirivimab and imdevimab in patients admitted to hospital with COVID-19. And this is an investigator-initiated, individually randomized, controlled, open-label platform trial to affect the effects of the COVID, the casirivimab 4 grams and imdevimab 4 grams versus placebo. I mean, of course, you clearly see here, these are much higher doses that were used in the earlier trials. And 94% of the patients in this particular analysis have received corticosteroids. Now, the primary endpoint focused on seronegative patients. Results from the fertility analysis of 2,000 study individuals in hospitalized patients indicated that seronegative patients may benefit more from this antibody cocktail than seropositive individuals. And therefore, the focus has been on the seronegative individuals who are hospitalized. And the data has shown us that almost a third of the patients, when they are hospitalized in the wards, are still seronegative. When you look at the placebo arm, as well, when you look at the usual care arm, as well as the antibody cocktail arm, the baseline characteristics are very well matched as far as the age, gender, number of days since symptom onset, number of days since hospitalization, the respiratory support required, that is no oxygen, simple oxygen, NIV, invasive mechanical ventilation is concerned, it's very well matched. If you look at the comorbidities, they are also quite equally well matched. As far as the steroids are concerned, that is also quite well matched. Both groups received equal number of patients received the steroids. And important thing is, because the recovery trial looked at has been evaluating multiple therapeutic strategies, the number of individuals receiving azithromycin, colchicine, and aspirin was also equal in both the arms. And clearly it showed that the CAS-IMD antibody cocktail reduced the risk of death by 20% in seronegative patients. So if treated with usual care, only seronegative patients had twice the risk of death compared to the seropositive patient, that is 30% versus 15% mortality. And this is very clearly seen in these three graphs. This graph A is seronegative patients, where you can clearly see the benefit of the Cas-IMD antibody cocktail plus usual care. And if you look at all participants, there's no significant benefit. And also in seropositive patients, there is no significant benefit. So the 28-day mortality in seronegative patients, if you look by other subgroups, was again in favor of the Cas-IMD antibody cocktail. If you look through the age groups, less than 70 or more than 70, gender, male, female, again, both similar, also benefit across ethnicities, benefit across the days of since symptom onset, less than 7 days or more than 7 days, and it was independent of the respiratory support that was required. So therefore, in seronegative groups, individuals, the Cas-IMD cocktail fared better, plus usual care fared better than usual care alone. So Cas-IMD reduced both the risk of death by 20% and hospital stay by 4 days in seronegative patients. It also reduced the risk of ventilation in seronegative patients. And if you looked at the NIV, there was a 15% reduction in those seronegative individuals who received the Cas-IMD cocktail plus usual care. And there was a 33% reduction in the use of invasive mechanical ventilation in those receiving the Cas-IMD antibody cocktail. The primary and the secondary outcomes overall and by baseline antibody status are represented here. And in this plot, you can see here that the death, as far as the death within 28 days was concerned as an outcome, in the seronegative individuals, the outcome was less likely if they got the antibody cocktail. Discharge alive from hospital was more likely if they received the antibody cocktail, and invasive mechanical ventilation or death was less likely if they received the antibody cocktail. So as far as the safety information and potential infusion reactions are concerned, there have been reports of fever, sudden hypotension, thrombotic events, sudden worsening in respiratory status, and clinical hemolysis. There are the 5 reports which have been reported as an adverse reaction believed to be related to the REGEN-COV. So the interpretation of this data is that in patients hospitalized with COVID-19, the monoclonal antibody combination of casirivimab and imdevimab reduced 28-day mortality among patients who were seronegative at baseline. Again, the key messages I already discussed with you. This is a large study, and in seronegative patients, reduced mortality by 20%. It reduced the need for invasive mechanical ventilation and also reduced the duration of hospitalization. And the benefit of the Cas-IMD antibody cocktail in seronegative hospitalized patients was seen all across the subgroups, including those with respiratory support. Now, slightly further, this is again the recent data which talks about the expanded authorization of REGEN-COV for post-exposure prophylaxis in certain individuals who are exposed to a SARS-CoV-2 infected individual and who are at high risk, or those who are at high risk of exposure to an individual in an institutional setting. That means we are now talking about a post-exposure prophylaxis or at a high risk of infection if in a particular institutional setting, such as nursing homes or prisons, etc. So that's where the role of this antibody cocktail was looked at. Individuals had to be more than 12 years of age, given within 96 hours of a household contact being diagnosed with SARS-CoV-2, randomized 1:1 to receive 1200 milligram of REGEN-COV versus or placebo via subcutaneous injection. And the primary efficacy was proportion of patient participants without evidence of infection or prior immunity who subsequently developed symptomatic infection during a 28-day efficacy assessment period. Now, I just want to highlight 2 important messages that come here. The proportion of participants who have a symptomatic RT-PCR confirmed SARS-CoV-2 infection was less likely in the REGEN-COV group. That was 1.5% versus 7.8%. So there was a risk reduction of 81%. And the proportion of all participants with viral load more than 10⁴ copies per mil was lesser in the REGEN-COV group at 1.6% versus 11.3%. That was a risk reduction of 85.8%. And of course, there was further analysis about the number of weeks of symptomatic COVID-19 confirmed RT-PCR, that was lesser. The number of weeks with a higher viral load, that was also lesser in the region COVID group, and the number of weeks of any RT-PCR confirmed SARS-CoV infection, whether symptomatic or asymptomatic, was lesser in the region COVID group. So to conclude, a single subcutaneous administration of 1200 milligram of region COVID dramatically reduces symptomatic and asymptomatic infection over a 28-day assessment period in uninfected individuals at high risk of SARS-CoV-2 infection with an acceptable profile, and therefore the claim is made to be considered to rapidly protect at-risk unvaccinated individuals or those who remain susceptible to SARS-CoV-2 infection despite vaccination, particularly those who are likely to fail who are likely to mount a good antibody response after vaccination. So this is my last slide. To summarize, India has witnessed a surge of COVID cases. Majority of patients develop mild to moderate disease. Inhaled budesonide is routinely available and can be easily included in management of mild to moderate COVID-19 disease. Casirivimab and imdevimab are recombinant human monoclonal antibodies that target the receptor binding domain of the spike protein of SARS-CoV-2, which can produce viral replication. And this cocktail aids in reduction of the risk of hospitalization and death in patients with mild to moderate disease who are at a high risk of progression to severe disease. Thank you very much for your attention.
Thank you very much for that excellent presentation. We've now got a few minutes for a discussion and some questions around this. For any of the participants who would like to ask questions, I encourage you to put them into the chat line, but there's a few things which a lot of things I'd be quite happy to talk about, so I'm going to start talking about them. Parvez, can I ask you maybe a little multifaceted question here, because it's around this issue of serotype variation in pneumococcus, and it did seem, well, one, I took your comments at the end about where we have data about serotype distributions, and whether how you maybe should be fine-tuning your vaccines to reflect what are the dominant serotypes in your community. And I wondered if you could just expand a little more on that in terms of where we do have useful information from and where the big gaps might be. And I did wonder whether this, in your data on hospitalized patients, I think it did show that the protection offered against hospitalization and severe disease was quite variable. It went from quite low percentage to quite high percentage benefits. And is that a reflection of the serotype vaccine mismatches in those populations? Is that what accounts for most of the failures of vaccinations, or are there other population differences that say even if you've got a good match, you don't get as good a response? So those two bits about whether we tune our vaccines right, and the other about whether mismatches are responsible for the differences in benefits that we may see.
So thank you for that question. And unfortunately, we don't have a great epidemiological data available from the countries which have the highest burden of infectious disease. And that includes the developing countries, including India. We don't have, if we talk of serotype epidemiology, two studies have been done in India, and they have given variable results. And the last study was done in 2014. So we have big gaps in our epidemiology, and that's why we really don't know what is the good match, what is a match between the vaccine that is rolled out and the actual burden of the serotypes in the community. And if we talk of globally, and we know that pneumococcus has nearly 100 serotypes, and of the serotypes, it's the 27 serotypes that mostly cause most of the diseases. And what has happened is that after the introduction of the conjugate vaccine, there has been a sudden reduction in the serotypes of that were contained in these conjugate vaccines, and that has been seen across board, most pronounced in those aged less than 5 years, and that is all pneumococcal disease causing, all pneumococcal causing invasive pneumococcal disease reduced by as high as 67%, and those contained in the serotypes reduced by around 90%. Yes, so that is a fair assessment that the reduction occurs directly in proportion to what is contained in the conjugate vaccine or the vaccine that is given, and that obviously has an effect on the burden of the disease and the mortality and its effectiveness and efficacy.
And I guess there's some parallels with the issues with flu vaccination of trying to get that broader based responses by looking at different approaches to the vaccines.
Exactly. I mean, Dr. Subara was talking about something called a universal flu vaccine, and we aim to have something like a replica of that in the pneumococcal disease as well, looking at conserved regions and targeting those regions rather than the capsular polysaccharide, which changes from one time to another.
Well, that does nicely segue into your presentation, Kantor, which, as I said, was fascinating. Towards the end, when you were talking about these approaches we had, and I was quite fascinated by this bit about, which I hadn't really appreciated, about the duration of protection you might expect as you go to those more universal vaccines. And we've seen it with a number of our vaccines now that we're looking at having to vaccinate people more frequently than we thought we might have to. And it's happened with mumps and measles, maybe for different reasons. But do you think, and with COVID now, we're facing the fact that we're anticipating we may have to revaccinate relatively frequently. So is that just something we're going to need to accept, that really we, in terms of how we're going to have to approach better quality protection?
So that's a good question. I think it's a little muddied by what comes before. So, you know, we've all had exposures to influenza. And so there's a sort of background rate of people having had prior exposure to influenza and have some response to immune response to the conserved proteins. And what we're learning with this HA stem is really an issue of immunodominance. So you can elicit a response to the HA stem, which is highly conserved, and it gives you much greater breadth. But that response is not sustained. It drops off. And as soon as in experimental animal models or in people, when they're exposed to the next strain of influenza, again, the head dominates. So we've got this dominance of the head over the stem. And until we find a way around it, either with adjuvants or platforms or these kind of these nanoparticles with, you know, a mosaic where you're really trying to change how the immune system sees that stem, we're struggling with that, with the longevity of the response. So it's, you know, it's really exciting that we have the responses, but they are dropping off more rapidly. I'm not sure there's a direct parallel with what we're seeing with the COVID-19 vaccines, because I don't know how much of that is simply that it was a totally naive population and we're seeing these antigens for the first time. So I think it's probably a mix of issues.
And you answered my other question, which was, why don't we have, because I mean, I know at conferences for the last 2 decades, at least, I've heard about, we found a common epitope that will give you broad protection, and we still don't have a universal vaccine. But I think you've probably answered the question as to why that has.
I remain optimistic that, I mean, the science is really exciting. And so now, especially with all the advances with COVID-19 vaccines, I'm really hopeful that we will bring together different delivery, different platforms with the choice of immunogen. And I think we'll get there. It's just not going to be overnight.
Yeah, it's going to be a very long night as well. Righty-ho. Now, about the monoclonals, Dr. Chedjed. I was, one of the issues that's come up with monoclonals now is we see particularly the ones that are directed at the spike proteins, well, obviously the ones that are directed at the spike proteins, is the issue of emergence of resistance, which we've seen now with some of the variants to some of the monoclonals. Is this going to be a real problem? Is having two different targets enough to have it, or are we going to be continually chasing our tails also with the monoclonals as well as with vaccines? So you're muted still.
Yeah. So I mean, I didn't get a chance to talk about the resistance, and there seems to be the region COVID. It retains the neutralization potency against current variants of concern and interest. I mean, that is what is claimed at the moment. The in vitro escape studies, which have predicted emergence of viral variants in animal and humans that have been studied. And it seems that 3 non-competing monoclonal antibodies in combination can reduce the variant risk compared to the combination of 2. So at the moment, we're talking a combination of 2. It's possible that we may be going to a combination of 2. At the moment, I mean, what the region COVID data I have looked at is it says does not lead to emergence of viral variants. But then also what they're saying is that as far as the mutations are concerned, will the same antibody cocktail be as effective against the mutations? Will there be an escape mechanism? And there are various lineage with spike protein substitution, such as the UK origin, South Africa origin, Brazil origin, California origin, New York origin, including the India origin. It seems at the moment that there is no escape with the Cas-IMD antibody cocktail, but I think this is likely to happen, and it is possible that we can see a combination of more than 2 antibodies in the coming.
Can I ask, when the data that Regeneron wasn't as effective, or in some cases had minimal effectiveness in seropositive people, I presume they were seropositive from vaccination or from?
So the seropositivity was checked. I think they looked at the antibody, I think the nucleocapsid. That means if the individual upon exposure to the disease or having been diagnosed with the disease had already developed antibodies, but of course had already had an inflammatory response, and therefore the progress. And of course, if the individuals were already vaccinated, they've still developed the symptomatic disease. So they said that the vaccinations does not influence the administration of the antibody cocktail. And as far as the hospitalized patients were concerned, I think they looked at the nucleocapsid antibody, because the vaccine antibody was not taken into consideration for that.
Okay, but is that loss of reduced effectiveness in severe disease then for seropositives related simply to the fact that there was no additional benefit? They already had the antibodies, and you weren't going to achieve anything.
Because I think the way these antibodies act is that they act on the membrane, they reduce the replication, the infectivity. I think that has already happened for these individuals who've got these antibodies. That's already happened, and despite that, I think they're already into the inflammatory response. So that is my understanding.
Okay. Yeah. Sorry. Yes, Kanta.
I was just going to say, I think it may be a reflection of the duration of illness. So if they've been ill, it's a marker or surrogate for how long they might have been ill, or time since exposure to COVID-19. So if their exposure was long enough ago that they're making antibody, that the monoclonals don't work as well.
Okay. I mean, I'm going to have to draw it to a conclusion because we're up time, but I think it's really interesting with the different monoclonals we have now coming through that are going to work in different ways, both the ones that are directed at the virus and the ones that are directed at, you know, the cytokines, and the fine tuning of how we use monoclonals is, I'm sure, is going to be a challenging and really interesting and hopefully productive exercise for management, and hopefully some of it will flow over into flu as well. Anyhow, I will draw this to conclusion. I thank the speakers very much for 3 excellent presentations and some excellent discussion. And I'm going to hand back to Kim, I think, now to take us through the closing bits.
Thank you, David. There is one question that has come through the system that I can see here. Are you able to see that?
Oh, yep. Sorry, it was behind the pictures of the speakers. Okay. Dr. Vinaya Gopal has said, is there known immunological cross-protection from influenza to COVID-19, as there are reported lesser cases of influenza after the emergence of COVID-19, despite knowing that masks and safe distancing are protecting us from influenza? So we would like to take that in terms. Yes, Kant.
Yeah, so no, we don't think that there's any immunologic protection, cross-protection offered by influenza against COVID-19. The absence of influenza circulating is likely a consequence of a couple of different things. It's changes in behavior, possibly competition between viruses, and changes in restrictions in travel and other things. So I don't think it's an immunologic explanation at all.
Yes, and vice versa, I presume. There's not likely to be protection from influenza from COVID-19, so we still don't have to get vaccinated.
And someday flu will be back, and it is already in India. Yeah. So, yeah.
Oh, okay. Well, thank you, Kim. I finished my duties now.
Thank you, David. You have indeed.
I will hand over to you then.
Thank you, and a wonderful job, I might say, David. Thank you. And Kanta, Prashant,